All right, so our topic for this discussion today is going to be patient destination decisions and interfacility transfers. So, why are we talking about this? Well, freestanding EDs are becoming more common in our communities. Ohio Health has opened up two in the past 6 to 7 months, and there are more on the horizon. And these freestanding EDs represent a challenge sometimes, but they're also a tremendous resource for us because they can serve as suitable destinations for some, but not all of our patients. And we're going to discuss today some of the potential patient types that are best suited for treatment at a freestanding. We've also seen an increased number of 911 calls from freestanding EDs for emergent transport of patients to a hospital-based emergency department. So we're going to talk about what our expectations should be from these facilities and what the facilities should expect for us, and particularly in terms of our policies and procedures or our clinical standards that are in effect and have an influence on patient transport decisions. And also going to briefly discuss some changes that we made to our interfacility transfer clinical standard, which has been present for several years, but is going to have a revised version going online July 1st. So for the purposes of our discussion today, there are really two clinical standards that apply, patient transport and interfacility transfer. We've tried to make them consistent with each other, but the patient transport clinical standard is preeminent. It is going to be relied upon to govern our patient transport decisions. The interfacility transfer clinical standard has to do with what we're going to do when we're called and what are our steps in place to safely transport patients to the appropriate facility. So when we talk about freestanding EDs, we always have to keep in mind the health and safety of our patients is paramount. Everything else is subordinate. So we need to make clinical decisions that are in the best interest of our patient. Sometimes that may be in conflict with other considerations, but the patient's health and safety is always first. So transport decisions. What patient may be suitable for a freestanding ED? So before we get into which patient should we bring there, let's talk a little bit about what resources are available at the freestanding EDs. We have in our service area 3, if not 4, freestanding EDs. In our service area, the first freestanding was Diley Ridge, and since then we've added, or there's been added, Ohio Health Perkington, Ohio Health Reynoldsburg, and just last week, Ohio Health New Albany. So these freestandings are available. They are generally staffed by an emergency physician with nurses, and they may or not have respiratory therapists. My understanding that Ohio Health, Reynoldsburg, and New Albany both have 8 beds with a physician, 2 nurses, and other support staff. These facilities also have standard radiology available as well as a CT machine. They may or may not have full ultrasound capability, and they may or may not have MRI available depending on the circumstance, depending on the facility. Generally, however, if they have fully capable ultrasound and MRI, they're available for limited hours per day. They may be available for 8 or 10 hours or 12 hours on a weekday. They may not be available nights and weekends. These facilities have limited labs, but the lab capabilities they have are well in line with the types of patients you expect to go to a freestanding ED. So they can do blood counts, they do blood chemistries, they can do urines and urine pregnancy tests. They can analyze coagulation studies. They can do some drug screening or drug levels. So if you're worried about a Tylenol overdose, they can do an acetaminophen level. If you're worried about a overdose on Dilantin, they should be able to do a Dilantin level. But they don't have the full list of laboratory testing available in-house that you'll find at a hospital. So, they generally will have everything they need in line to take care of patients that you expect to be brought there. They have a limited number of oral and IV medications. Typically, again, it's the medications you'd expect them to need for the walk-in emergency medicine or emergency services business. They all have resuscitation equipment available, and they do not have inpatient or observation beds except for Diley Ridge. Diley is seen as a hospital, and they have 10 observation beds in the back. All these facilities have the ability to observe patients in the beds for a series of hours for response to treatment, but long-term observation is generally not something that's going to be provided at one of the freestanding facilities. So, you need to consider that, or we need to consider that when we take patients to these facilities. What type of patient is best suited for transport to a freestanding ED? Well, generally, if they should not be suffering from time-critical events such as STEMI, stroke, trauma, or sepsis. They should have stable vital signs. They should not require airway adjuncts such as CPAP. They may require supplemental oxygen, but it shouldn't. But they shouldn't require any significant other interventions for their airways. EMS providers should reasonably expect that the patient has a condition for which they can be treated and released by the freestanding ED. So there's going to be a little give and take on that, but if it's obvious the patient needs to be admitted to the hospital, then they should not be transported to a freestanding ED. If they have a need that can be easily met by these facilities, they are a good candidate to be taken there, such as wound care, fracture care, minor to moderate illnesses and injuries. They should be able to manage most of those patients. And then patient transport clinical standards does not require the transport to a hospital-based ED. For instance, there are conditions that are specifically identified in our transport plan that say you have to take them to specific hospitals or to a hospital-based emergency department. Our goal should be to take the patient to the right place the first time. So our goal should be to take a patient who's going to require admission to a hospital-based emergency department where they can be treated, stabilized, and then admitted to the hospital. Our goal should be to minimize the number of secondary transfers from freestanding facility to a hospital-based emergency department. In other words, we shouldn't be taking patients who are going to require admission to a freestanding ED. Some specific types of patients that are not suitable for a freestanding ED. Again, any patient who meets special destination center criteria. So if you're talking about a stroke patient, they need to go to the appropriate level of stroke care. If you're talking about a trauma patient, they should be taken to a trauma facility if they meet state trauma triage guidelines. So generally, if a patient has a time-critical event, such as major trauma, cardiac events, stroke, post-arrest patients, or septic patients, they should go to the appropriate hospital-based emergency department. Specifically regarding cardiac arrest and post-cardiac arrest patients, the freestanding EDs generally do not have support services available for a family to deal with a patient who dies from, or to deal with a family member who's died from a cardiac arrest or other unexpected death. And these facilities, generally the smaller ones, don't have the capability of managing these patients and so on. And so, do we really want a facility that has 8 beds to lose one of those beds to a patient who has died and is waiting to be picked up by a nursing home in 3 or 4 hours? So the patients who have suffered cardiac arrest should not go to a freestanding ED. Unstable patients generally should not go to a freestanding ED. We have the capability to stabilize. The EDs have the same meds, the same equipment that we do. So why would we stop there for stabilization if we already have that capability? And just as a side item, always be aware of the ill diabetic or the ill dialysis patient. These patients are the sickest population of patients you're going to be taking care of. And they have all sorts of problems that can pop up as they're being assessed. So always be aware of the ill diabetic and the dialysis patient. And patients who have an obvious need for surgical intervention should not be taken to a freestanding ED. Take them to the facility that's got the best capabilities to meet the patient's needs. And generally, patients with significant postoperative complications or complaints should go back to their home hospital where they had their surgery performed. Patients in labor should not be taken to a freestanding ED. These freestanding EDs have no obstetrical capability other than to do emergent deliveries. They generally do not have the ability to monitor the baby. So if you have a pregnant patient who has a complaint related to pregnancy or a complaint that can have a significant effect on their pregnancy, then they should be taken to a hospital-based emergency department that has obstetrical capabilities available out the back door. Pediatric patients generally are not suitable for freestanding EDs if they have significant medical problems. If they have some minor croup, they have a minor injury, they can be well cared for in a freestanding emergency department. If you have any concerns about whether or not the patient may be suitable for a freestanding ED, contact the freestanding and ask them if they're comfortable taking care of the patient. Also, if you have a freestanding ED in your community, feel free to stop in and ask them for some idea of what their capabilities are for pediatric patients. Then psychiatric patients who require physical or chemical restraint are not candidates for freestanding ED. So if the patient is violent, if the patient needs an injection of Versed or ketamine or both, they are not a candidate for the freestandings. The freestandings have limited space, have limited staffing. They generally have no security staff on board. So a violent, uncooperative patient is not a good candidate for a freestanding ED. So generally when I talk about various clinical standards or protocol items, providers come up with what ifs. So I thought I'd give a quick talk on or a quick mention of some what ifs to use as examples for patients who may or may not be a candidate for freestanding. So from the perspective of hospital-based EDs, I've got them marked as they're capable of managing all of these patient types. Patients with uncomplicated lacerations need a couple stitches and then go on discharge home. They are perfect ideal candidates for a freestanding emergency department. Patients with significant injuries such as a degloving injury, I think it's very obvious they are not a candidate for freestanding. Patients with simple closed fractures and dislocations should be considered potential candidates for freestanding. Patient having ankle injuries, shoulder injuries, dislocated shoulders, they are candidates for freestanding. I have two asterisks there just as a reminder or as a prompt to me to mention that if you have a patient who has a closed dislocation or a closed fracture but has significant medical problems such as COPD, heart failure, uncontrolled diabetes, they may not be a candidate for a freestanding ED simply because patients generally require intravenous sedation for a fracture or joint reduction, particularly you're talking large joints like the shoulder or the hip. So if the patient's on supplemental oxygen at 3 liters per minute, they have chronic dyspnea. These generally are patients not suitable for sedation in the emergency department. If I have a patient like that, they generally go to the operating room where anesthesia can safely sedate the patient, monitor the patient's airway while the surgeon reduces the joint. However, if you're talking about a healthy 20-year-old with a dislocated shoulder and they've dislocated it 3 previous times, they generally are an easy patient to sedate and reduce and are a good candidate for a freestanding emergency department. If you're talking about dislocated fingers, that's perfectly suitable for a freestanding emergency department. If we talk about respiratory illness, patients with stable or mildly aggravated asthma or COPD could be good candidates for a freestanding emergency department. So if you have a patient with asthma, they have a mild flare-up, they ran out of their albuterol, they may need a couple treatments, their O2 saturation is normal and their work of breathing looks pretty good, they're a good candidate for a freestanding emergency department. However, if you look at the patient with the same symptoms but their clinical condition is worse, they're a COPD who's had to crank up their oxygen flow rate, they're an asthmatic who's sweating, retracting, can't speak in anything more than phrases or a few words. They are not a great candidate for a freestanding ED because they have the potential to deteriorate. They may require more time and effort than the staff can provide. I think an absolute, though, is if you have to use any airway adjuncts such as CPAP or intubate the patient, they are not a candidate for a freestanding emergency department. They should go to a hospital-based ED where they can be monitored, and if they worsen, they can be quickly and safely intubated or provided additional airway adjuncts. And I think this is best provided in a hospital-based emergency department. If we talk about chest pain, you can talk about cardiac versus non-cardiac. If you have a patient who most likely has chest pain that's not cardiac in origin and you're not worried about a pulmonary embolism or a pneumothorax, then freestanding ED is a good option for you. For example, a patient trips and falls, hits their ribs on a chair, they have some rib pain but are otherwise stable with no evidence of a flail chest, pneumothorax, and no airway compromise. They're a good candidate. A patient who's got bronchitis, coughing up some yellow phlegm, have a little bit of chest wall pain or burning in their chest when they cough, good candidate for a freestanding emergency department. But if you however have a patient who's having chest pain, it's suggestive of cardiac origin, or you're concerned about a pulmonary embolism based on risk factors, or they look sick, or they have a tachyarrhythmia such as atrial fibrillation with a ventricular rate of 150, 160, those patients need to go to a hospital-based emergency department. Another candidate from an arrhythmia perspective that I think could safely be taken to a freestanding is a patient with SVT. You give them a dose of adenosine in the field, they break, they go to sinus rhythm. Good candidate for a freestanding emergency department. They can run some basic chemistries, observe the patient, and discharge the patient home with outpatient follow-up. Abdominal pain can be safely evaluated at freestanding, but again, think about severity of illness. You have a patient with abdominal pain associated with nausea, vomiting, and diarrhea, and when you get there, they're eating their Fritos and texting on their cell phone, then their abdominal pain can probably be evaluated and managed at a freestanding ED. Going to the other extreme, you have a patient with abdominal pain and high-risk features, such as you're worried about an ectopic, they haven't had a period in 3 months, and now they have pelvic pain that's severe and they're a little hypotensive. Ectopics a consideration, they need to go to a hospital-based emergency department that has the availability of true diagnostic ultrasound 24/7 and has the ability to transfuse and resuscitate a patient if they deteriorate. Same thing with potential miscarriages. Patients who are pregnant with vaginal bleeding, particularly if they're symptomatic and have abnormal vital signs, should go to a hospital-based emergency department. If abdominal aortic aneurysm crosses your mind, again, hospital-based. And if the patient has symptoms suggesting a bowel obstruction, I think it's in their best interest to go to a hospital-based emergency department. So here's a big maybe. How about overdoses or psych patients? I think you have to put a little thought into that. If you're talking about a patient with a history of anxiety disorder, they've run out of medications that has been prescribed for them previously, and they have no thoughts of suicide or homicide, they're just looking for a little bit of help and maybe a refill on their medication, freestanding ED may be a good option for them. If you're talking about a patient who's on antihypertensives and by mistake they took 2 of their antihypertensives today instead of 1, and they have normal vital signs, freestanding is a suitable place for them. If you have a patient, though, who took a significant overdose with the intent to cause self-harm, they are suicidal or homicidal, they need to go to a hospital-based emergency department. Freestandings generally do not have social workers or counselors available. They may be able to be medically stabilized at the freestanding, but they could be there for quite a while waiting placement. So patients who have significant psychiatric features need to go to a hospital-based emergency department. So I think I've covered a lot of the what ifs. There's no way I can predict all of them. If you have other questions or other clinical scenarios you're thinking about, please just post them on Workplace and I'll do my best to answer them. But I think by talking about the different options on this slide, you get a good sense in terms of what a good freestanding or what a good candidate for freestanding ED may be. So let's move on and talk about those transfers out. So we spent the first, 15, 17 minutes talking about who's a good candidate to be taken to a freestanding. Let's talk about moving patients out of a freestanding. So the basics to this is these freestandings are open. Patients can walk in. They will self-present. From the patient's perspective, it says emergency department, so they may self-present for a problem that is really not within the capability of the freestanding. Easy one is patients got chest pain, they walk into the freestanding and get a 12 lead EKG and they have a STEMI. Well, they need to go to a STEMI hospital. So your truck may be dispatched to one of the freestandings to provide patient transport out. We transport patients to the closest appropriate facility. It's been our policy for several years. It's been in our transport clinical standard. And because the freestandings have popped up in our communities, we haven't changed our standard. We are in the transport business. We're not in the interfacility transfer business. We're there because the patient has been identified with an emergent condition and they need to go to a hospital-based emergency department. Our transfer process is defined by two clinical standards. One is the patient transport clinical standard. It is preeminent. The second is the interfacility transfer clinical standard. That standard also includes two position statements issued by the MFATS boards over the past couple of years regarding patient transfer out, as well as continuing medications that were started by a healthcare provider that may not be in the EMS protocol. So I suggest you review them because I think it's important that you understand what you are permitted and are not permitted to do. So destination decisions, we transport patients to the closest appropriate facility, and our patient transport standard is in effect for all interfacility transfers as well. We'll have a little further discussion in the next slide about the appropriate facility, but generally we take unstable time-critical patients to the closest appropriate hospital. We have had occasions recently where we drive patients who are unstable past more than one suitable hospital to get to the destination hospital. Our goal is to avoid doing that. We're in the time-critical transport business. Our goal is to get patients to the closest appropriate facility. With a time-critical diagnosis, time is important, so we should get them to the closest appropriate hospital. So for instance, we shouldn't be driving STEMIs past a STEMI hospital, and we shouldn't be taking hypotensive patients with IV pressors infusing to the other side of town when there are other closer hospitals with the same treatment capabilities. So we'll talk a little bit more about that. Some additional things about closest appropriate. We have additional considerations in determining what is the closest appropriate facility. So if the patient was at a hospital in the previous 30 days and discharged and now presents to a freestanding with a complaint related to that original discharge condition, then we should be taking them to their hospital of record if they're hemodynamically stable. So if the patient had gallbladder surgery at Ohio State and now have complications of that surgery, we should take them to Ohio State because that's where their surgeon of record is. Generally, surgeons don't like taking care of other people's complications, and they don't want other surgeons taking care of their patients with complications. Another thing to consider is patients with chronic medical conditions who are stable and who consistently receive care from a specific hospital. Our goal should be to get them to that facility. For instance, if a patient had a kidney transplant and they show up at a freestanding emergency department and now they have evidence of complications of that transplant, such as rejection of the transplant, our goal should be to get that patient back to Ohio State, which is their hospital of record. Other considerations in terms of destination decisions are time and travel distances. So we may be in a position, and for Ohio Health New Albany, I think this is particularly true, where the transport options really are not that much different if you consider travel time and distance. And this could be changed from day to day based upon travel conditions and traffic. So, 8 o'clock in the morning, inbound traffic on 161 may make certain hospitals more attractive or less attractive based on what you anticipate to be travel times. Things to do before you leave the emergency department. So you get called, you're on the scene, you're ready to move the patient, report's been given. What do you need to do before you leave? And we've got some items here, and the first four are bullet points based upon our own experience. So first thing one thing you need to do is verify the receiving facility. We have had providers transport patients to the wrong facility based upon their usual transport patterns. And that patient was supposed to go to a different hospital than they're used to taking the patients. So they showed up at the usual hospital who was unaware that the patient was coming, and the hospital receiving or expecting to receive the patient never got the patient. Verify the receiving facility is aware of the patient. So it's not just make sure you know where you're going, but make sure the hospital that's receiving the patient has accepted the patient, generally that's not an issue. But verify that. Verify all of your infusion line or IV lines and IV infusions. Make sure, if the patient has 3 IV bags hanging with 3 sets of tubing, you know which ones are connected or which ones go to which peripheral IV. We have had occasions where a patient has a need for a medication administered en route. It's given through an IV, but the IV is not connected to a vein, and the medication ends up on the gurney and not in the patient. And then the crew is wondering why the patient has not responded to the medications. And then also verify all IV infusions, so that if there are bags hanging, make sure that the bags are just saline, or verify that they do or do not have any other medications mixed in with them. If you're uncomfortable transporting a patient due to equipment or medications, ask for a nurse to go with you, or think about asking for the transferring center to make some accommodation. That might include discontinuing whatever's infusing. So an easy example is, we occasionally have to move patients out of Mount Carmel to Albany, and they may be coming out of the operating room and they have propofol infusing. Well, we generally don't want to move patients with propofol because we need a pump. So what we will do is they'll discontinue the propofol, give the patient a good dose of paralytic as well as a narcotic and a benzodiazepine, such as Dilaudid and Versed or Dilaudid and Ativan, and that's enough to keep the patient sedated and comfortable during the transport to the hospital, where they can then restart the propofol if they think it's necessary. So if you think you need a nurse, ask. If there's something that can be done to the patient's treatment, such as medications infusing prior to transport, ask. Also, be aware of the position descriptions that I talked about from the EMS board regarding interfacility transfers and transport of patients with pre-existing medical devices or drug administration. It's good to know that information for background. And then again, use a checklist. We have one in the clinical standard. This is what it looks like. It's meant to help you. It's meant to help you avoid the traps and pitfalls that we've had over the past. It's my suggestion that you make some copies, keep them in the truck, and if you need it, pull it out, fill it out. When you get back to the station, scan it into your run record so that it's available for review in the future. It's not overly cumbersome. It will keep you from getting into trouble and those pitfalls that I discussed earlier. About done. Just a couple final comments. Urgent care centers, physician offices, surgery centers, and so on, they are not covered by the interfacility transfer clinical standard. They are considered scene runs, and in that circumstance, the patient transport clinical standard applies. If there's a disagreement between you and the facility regarding patient treatment or destination, don't let the patient get caught in the middle. If there's a very strong argument or suggestion the patient go to a specific location, I would not spend time arguing with the staff and the physician. Make sure the patient is aware of where they're going. Make sure the patient's aware of any potential risks. And take the patient to that facility. Then let us know, let your supervisor know. We'll go back and talk with the facility at another time. But let's not let the patient get caught in the middle. Any possible savings in time by taking to the closest appropriate facility may be totally lost if we stand there arguing with the staff and providers at the freestanding ED. And then finally, the patient has the final word. If the patient has an emergent need for transport but wants to go to a specific hospital, they can make that request and we should honor it. The patient has the final say regarding their health care. If the patient is insistent, explain your concerns, explain your reasoning, but if they still want to go to a facility that's farther away than the closest appropriate facility, they can make that request and we need to honor it. So finally, I think that's it. If you have any questions, please post them on Workplace. I appreciate your time and listening. I'm glad to hear for any comments, and I'll put any comments and questions out for the general viewership to see. Thanks again.